Hi, I'm Dr. Bob Dannenhoffer, the Public Health Officer for Douglas County, with another of our Facebook Live shows tonight. Tonight's going to be a special show. I was supposed to give a talk tonight to another group at exactly the same time, and I can only be in one place at a time, so I'm actually going to do that talk tonight as part of our Facebook Live. We'll still have time to go and do our review and answer your questions, but I'd first like to go ahead and invite them there. So we will get to the Facebook questions. We will get to the worldview and what's happening here. But what I'd like to do tonight is start from the beginning of this pandemic and kind of do a recap. We're now into it over a year, and this is a great time to recap some of the things that we've learned about this pandemic from the very beginning. So the first question is, when did this all start? Well, I think the best evidence is that this probably started somewhere in the fall of 2019. I think there's very good evidence that it did not start any time before that. We've not been able to find people with antibodies to this virus before the fall of 2019. And so it probably started in the fall of 2019. Where did it start? It almost certainly started in China. There's been no evidence that this disease was present anywhere else in the world before it was prevalent in China. How did it start? I think we still do not know the answer to that. I think the best guess is this started in bats, and then from bats either moved to another animal like a pangolin and then to people, or moved straight from bats to people. So bats are interesting in that they are responsible for far more disease than you'd expect. And why would that be? Well, bats, little rodents that fly, and they live for a very long time. Unlike other rodents, mice and rats and whatever, they typically live a couple of years. They typically don't stray far from where they were born and then they die. They have sort of regular immune systems, and so they tend to carry some disease, but they're not the predominant source of disease in the world where bats are. And bats are different. Bats tend to live a very long time. They can live 30 or 40 years, and over that time pick up lots of disease. The second is obviously they fly, and since they fly, they can interact with many other bats in their lifetime, and they tend to live in incredibly big, dense clusters. So you see some of these caves where they live, where there are thousands or millions of bats in that same area. So a disease in that area can spread. And because of that, bats have a very, very unusual immune system. Their immune system is very tolerant of carrying viruses without the viruses really attacking you. So bats are largely responsible, we think, for Ebola. So we think it's fruit bats in Ebola, and then they give it to other animals along the way, including apes and humans. We think bats are the #1 reservoir for rabies in Oregon. So we think about cats and dogs, but really truly bats are the place where rabies stays. If we have almost no cat rabies or dog rabies. Almost all the time that dogs or cats are infected, they're actually infected by a bat. So a bat is dying and the cat or the dog plays with it, and that's how they get rabies. So bats probably played a role here. Now, did it go from bats to a person? Probably. And how did that happen? Well, we do know that there were researchers in China who were studying bats and collecting stuff in the bat caves, and it's certainly possible that they picked up during one of those collection activities. It's also possible that a bat got into someone's house and gave it to them that way. I think the wet market probably played something to do with it, but it probably came from bats to people and then started spreading around people. There was a theory that it might have originated in a laboratory. I don't think that's very likely, in that it's a very sophisticated virus, and it's unless the people working in that lab have some technology that has not even been imagined, it's hard to believe that they could have created this de novo. And so I think the best thought is that this was bats maybe there were pangolins or others, and then in people, and then it started spreading in China in the fall and winter of 2019. It was then very clear that in the beginning of, in January, they were seeing a rapid increase in this new disease. And it's also very clear that the Chinese tried to hide this at the local level of what was going on. And that almost certainly caused a delay in understanding what goes on. But by the middle part of January, it was very clear to all of us who were looking at this that this was a new, very scary and different organism. Now, early on, there was a lot of downplaying of what went on, but you only had to see a couple of things to really worry you. Probably the most among them was the ship called the Diamond Princess. So the Diamond Princess was the cruise ship. It picked up one infected passenger. Within a few days, a bunch of people were sick. Within a few weeks, more than half of the ship had the disease. Truly remarkable in the spread. Because we see other things spread among ships, like flu, and you'll get one and then have maybe a dozen cases of it. Have that number of cases was truly remarkable. We know that norovirus spreads on the ship, but it spreads because a lot of people have vomiting and diarrhea. In this case, people only had a respiratory illness, and the quickness of the spread of the respiratory illness was just absolutely stunning. So the first response that the U.S. had to this was to shut off travel. And shutting travel is not an unreasonable thing because it can buy you some time, but I think in retrospect, it was very badly handled. In all of the cases, they basically said, well, people who are in the countries where there's disease, starting first with China and then with Europe, please get back to the US. And unfortunately, people who might not have otherwise traveled wanted to travel so they wouldn't be stuck in those countries, and they traveled while they were brewing the illness. It was early on thought that by screening for temperature, you could find the people who would likely be contagious, and it turns out that was a tragic mistake. What we know now is that people are most contagious before they have any symptoms and well before they have fever. And so that screening for fever was not very effective, and it was shown that it missed almost all the cases of people who were sick, and almost everybody who had fever didn't have COVID, had some other reason for fever. And so we made a big mistake and brought back to this country many sick people. The first one was a case in the state of Washington. And this was an interesting story because this person was seen, he wasn't very sick, but about a week later he really got quite sick. And so what we learned early on then was that early on in the illness, people may not have a lot of symptoms, but that in the people who are going to get sick, they're going to get sick 8 or 10 days after the first onset of illness, and then they're going to get really sick over the next week, and that's then going to tell whether they're going to live or die, so that the peak time of death is the 13th, 14th, or 15th day of infection. And so it really is some things that we learn, and perhaps learn too late. Well, then early on when we got there, I think we as a country did not necessarily recognize how serious this could be, and we were slow on a couple of things. And one of the things we were slow on was recognizing that if this pandemic hit the U.S., that protective equipment would get in short supply. So actually in January and February of 2020, the U.S. exported, that is, sent away to other countries, an absolutely historic amount of PPE. So rather than recognizing January and February that, ooh, this could be bad, we should hold on to the stuff, it went out of its way to export to other countries. So that in March, when it became clear that we were going to have a lot of disease in this country, the shelves were bare because we sent this to other countries. So I think we failed in that way with the PPE. And I think we also, in that time, failed with the development of the test. So early on, the CDC was tasked with developing this PCR test and sending it out to the areas. In retrospect, that was a terrible mistake. The CDC is very good at making tests for very accurate tests for very sophisticated diseases, and being the world gold standard for the test. What they have never done a lot of is making a lot of tests and sending them out. So they developed an exquisite test, which is still the gold standard, but they really struggled to send it out. So we were way behind in getting testing. In addition, early on in the testing, the US had a very strict view of how a new test would get approved. It would sometimes take a year, 2, 3, or even 10 years to get a new test approved. And early on in the pandemic, that is what we were using. So early on, we had a very strict policy for developing tests, and not many companies were interested because it did not appear that this was going to, at that time, that this was going to be a very long pandemic, and it didn't make sense to spend hundreds of millions or billions of dollars developing a test if this was going to be a pandemic that was going to be over in 3 months. So you'd spend all this money, not get approved for 2 years, at which point you wouldn't need the test. Well, by April, it was recognized that this was not going to be just a blip, so that rather than changing the guidance so that it would be easier, they basically got rid of the guidance, and then we wound up with this wild market of tests, some which were very good and some which were terrible. So really until about June of last year, we didn't have really good and reliable testing. Well, what we saw was that there was this peak in China, and this peak in China was really pretty stunning. Really within a few weeks, they went from no cases to about 80,000 cases and about 4,000 deaths. The Chinese approach to COVID at the time was a very, very, very strict lockdown. And so for those of you who were watching, were really worried. This was, you had to stay in your house. You could only leave for like 30 minutes a week. They were welding shut the doors of houses so that people wouldn't leave. It was very clear that this was an incredibly strict lockdown. This happened right during their Chinese New Year, and that would be as if for us, for Christmas, we would say that all of the country would be totally locked down, a pretty difficult to arrange thing. But the Chinese did that, and interestingly, although they had a lot of cases early on, they rapidly brought it down using just public health measures. They didn't have any good treatments or whatever else, and they brought it down just using public health measures. What happened is then the disease spread, and it spread interesting places. So it spread first to South Korea, probably from somebody in China who spread to South Korea. South Korea had a huge spread over the space of a month or so, and they approached their disease with strict lockdowns and lots of testing. But they were the first to show where these huge super spreader events, where one person, while they were asymptomatic, before they had any symptoms, could spread the disease to many, many people. And in fact, they found that one person was responsible for about 2,500 cases. Well, again, South Korea got their disease under control by strict public health measures and really lots of testing. The disease then next spread mostly to Europe, and especially to Milan, Italy. And some of the stories of what was happening in Italy are really heartbreaking. So, if you think of that area in Italy, northern part of Italy, it's a fairly established area, fashion capital, and it is an area that is maybe sort of like Oregon. It's an area that's known for its great food, like Oregon's kind of a foodie place, is known for its fashion, certainly Nike and Columbia, big sportswear places in that. And what they went from is they went from no disease to a tremendous amount of disease in really just a few weeks. And it totally overwhelmed the system. And some of the stories of the hospitals and other things getting totally overwhelmed, churches filled with coffins, is one of the heartbreaking early scenes of what went on. It then spread in Europe to France, Germany, and the UK. And then the United States did a travel ban on Europe, but gave a week or so for people who were sick or carrying the disease to come back. And then that, in retrospect, is likely what spread it to places in the US where people would come. So then, a few weeks later, New York became the epicenter, because most people who travel from Europe to the United States go through New York. And so then New York became the epicenter of the disease, and truly a heartbreaking place in New York. So the hospital I was born in, which is Wyckoff Heights Hospital in Brooklyn, was the epicenter of disease. That was the place that they would show aerial shots of lines of refrigerator trucks lined up to collect the dead bodies, and lines of people in the street, ICUs that were totally overwhelmed, people improvising PPE, and really, truly a terrible, terrible sight. Well, the disease spread in the New York, New Jersey area, and then spread to the rest of the country. And that was then, in the US, what we consider to be the first wave, starting in about February or March, and then moving through the next few months. We had then another smaller surge in the summertime. We then had a larger surge starting around the holidays, October, November, where the disease spread a lot. That surge in Douglas County was a little bit muted, was not quite as high as others. It then went down, and then we had another fourth surge here in the last few weeks. Now, if you look what's happening now in the world, the pandemic is very different where you look. So if you look right now in India, it is truly at its most desperate moment. They're having over 300,000 cases a day. They totally overwhelmed their healthcare system. They're running out of oxygen. They've run out of tests. So the number of new cases is hard to tell because they've run out of tests. It's also very, very strong still in South America, and it's strong in South America, especially in Brazil, Argentina, Uruguay, and so really tragically high numbers there. And then places in Europe, especially Sweden, France, and Turkey, where they're still having a tremendous amount of disease. So when I look at this whole pandemic, what I recognize is there were a lot of opportunities we missed along the way. And when I say it's we're all responsible that we missed along the way, that certainly we would hope we could do better the next time. So how is this all going to end? What are we going to see? Where are things going to go? So when I looked at this, I did a talk for my college about a year ago, and I said, how would this end? And what I like to do when I do those things is then to revisit them a year later and say, well, how close was I, or how far off was I? It turns out that we were a year ago when we looked at how this might end, we were not that far off. So let me tell you where we're at here. So when I talked about we talked about this virus, and this really is an unusual virus. And so what we've learned about this virus over the year is that it is not like many other viruses we've seen, and it's different in a couple of ways. One is that this virus seems to really prey on the old. Now, all viruses seem to affect older people more than younger people. Flu, pneumonia, many of those things tend to really affect us as we get older. But this one, the slope in older people is truly remarkable, so that people in their 20s and 30s, at least in the beginning, had very little disease, but people in the 70s, 80s, and 90s really died. What we also knew is that there was very little disease in children. Now, many diseases actually pick off kids. So you think of measles when you think of diarrheal illnesses, when you think of herpes. These are diseases where actually there's a really high mortality in kids and then gets less as we get older. Whereas in this, there was very little disease in children. Even in newborns born with the disease, rarely really suffered from the disease. So that was a little unusual about the disease. But now what we've also learned is there's this weird syndrome called this multi-inflammatory syndrome in children, or MISC, which is weird. It's kids who get the disease and then weeks later get this over when they no longer have the active disease. They get this intense inflammatory response that frequently winds them up in the ICU and causes lots of damage to the heart and to other vessels. And so we know about that. The other thing that's unusual about this is these amazing super spreader events. Now, we shouldn't be terribly surprised, because when SARS came out, and SARS is a related virus, probably also came from bats, It was not nearly as contagious as COVID. But what we saw was that there was one guy who stayed in a motel, and everybody on the floor of the motel got sick, and it was, well, how could this be? And it suggested that in the right conditions, it could really cause disease in lots of people. And then what we saw, the same kind of thing in these super spreader events, so that one person would get sick in a nursing home and then everybody would get sick. Or one person would get sick on a cruise ship and then over half the people would get sick with it. It was really, truly remarkable. The other thing that's unusual about this is the number of asymptomatic or really mildly symptomatic cases. So many diseases have sort of a range from mildly ill to very ill. But the range on this one, going from people who are truly asymptomatic and no symptoms at all to dying, is the widest range that you could ever have. And it's really very unusual for other diseases. So if you think of, measles is another terrible disease, but even the least sick kids with measles are still pretty sick, and the most sick die, but the range is small. The range in this disease is truly, truly, truly remarkable. And what we've learned now is that this disease is really wily in that pre-symptomatic spread. That is, spreading the disease before you have any symptoms seems to be the predominant way you spread the disease. Again, that's really quite unusual. When you look at Ebola, the only people who spread Ebola are people who are already sick. Measles spreads, but the people are already febrile when it spreads. Flu spreads a little bit pre-symptomatic, but most of the people, it's only maybe an hour or two before you're pre-symptomatic. This is a day or two before you get symptomatic, you spread. And so there are a lot of great individual stories where you can actually know when people develop symptoms and when they gave it to others. So there was this big choir group in Washington where 50 people got the disease from one person who was not symptomatic and then spread it to 50 more people. There was another one in New Jersey where somebody who was at a cocktail party and felt perfectly well, then traveled to South Africa and on the flight started to get sick and gave it to 40 people. And that's so pre-symptomatic spread is there. So this is a most unusual virus in those ways. And I would add to that is the number of ways it can mutate. So lots of viruses mutate, and so mutation of viruses is not that surprising. But the speed with which this one is mutating is truly remarkable. Now, we did not think it was going to mutate that much early on because these RNA viruses tend to mutate some, but not as much as other viruses. And this one actually has a proofreader thing in it, so it should mutate less. And yet what we've seen, at least over the last 3 or 4 months, is all of these new mutants out there that are now spreading across the world. So when we said, how would this end? And we, a year ago, predicted that it could end in a couple of ways. One of the ways we could say it could end is if you had a really good vaccine. And there was a lot of concern about that time because we've not really made good vaccines against respiratory viruses. And we were worried about, at that time, even a year ago, that vaccine acceptance could be low. And low vaccine acceptance would make it hard to get rid of the disease with that. And we worried about rare side effects. And then, just as we expected, the J&J vaccine has now had this several in a million severe clotting thing that would further degrade people's acceptance of vaccine and increase their vaccine hesitancy. And we were also worried about is things that we call true but unrelated. So if I got my vaccine and then a week later won the lottery, I wouldn't necessarily say I won the lottery because I had my vaccine, but if I got the vaccine and a week later then had a stroke, they'd say, well, you're a young, healthy guy, you had a stroke. Well, some young, healthy people do develop strokes. But I, of course, would look back and say, well, it's different than last week. Well, I had the vaccine, and we might then connect this to the vaccine, even if it may not be true. It might just have been random, and we were worried about that. So now we've got 3 excellent vaccines. I think there are more in the pipeline. They actually work far better than we ever expected. Actually, a year ago, if you told me the vaccines were 60% effective, I would have said, that's great, because that's about where we are at the flu vaccine in Turns out that they're about 90% effective. And when we look in our local experience, they're probably over 90% effective in preventing it. But we found this rare side effect, and vaccine acceptance is now our biggest problem. Well, there are other ways this could have ended. So what we thought is that maybe there would be good antiviral treatment. So when we look at other diseases that we've kind of snuffed out or really gotten down, it's not been a vaccine, but for many of these viral diseases, it's been excellent antiviral treatment. So for example, in HIV, we don't have a vaccine for HIV. The way HIV is now under control is really excellent medicines, some that you can take once a month that keep the disease or the viral load to zero, and basically the virus is probably hiding somewhere, but it's in unmeasurable levels. We have hepatitis C, no vaccine for that, but excellent antiviral drugs that over 95% of the people can be cured of the virus with an antiviral drug. Early on, the very first U.S. patient was actually treated with remdesivir. Remdesivir was an antiviral drug that was developed to treat Ebola, not to be the least bit effective against Ebola, but it sat on the shelf. And then when COVID came, they tried it in this. It seems to help a little bit. And so we have remdesivir. I think it only helps a little bit. It probably shortens your ICU stay, which is a good thing. It probably decreases the viral load, which is a good thing. And it might have some slight effect on mortality, but not a lot. And so really what we're left with now is just remdesivir. There are a couple of other diseases in the pipeline, but we don't really have them. Now imagine if we had a truly great antiviral illness. It would be, well, I got COVID and I went to the hospital and they gave me this antiviral treatment. I was in the hospital 2 or 3 days and then went home, but you had no deaths and none of these really bad outcomes. That would be great. Fortunately, we've not made very much progress on antiviral drugs, and really all we have now is remdesivir. Now, the other thing we thought is maybe this would end with a great biologic treatment. And so there are a lot of biologic treatments out there. You can't watch TV 5 minutes without seeing an ad for a biologic treatment like Humira or Xeljanz, all those kinds of different things out there, which are biologic treatments that work to get rid of whatever disease you're going to be treating. And so there are a couple of different ways to do it. One is you could use convalescent plasma. So take people who've had the disease, collect their plasma, and give that plasma to other people. It's something we've used for years. You could create a hyperimmune globulin where you would take the plasma from people, concentrate out the antibodies, and then use that. And so we do that for other diseases, like for botulism. If you get botulism, what we do is we get something called botulism immune globulin, called BIG, and for babies, baby BIG. Or for tetanus, we have tetanus immune globulin. For hepatitis B, we have hepatitis B immune globulin. And the thought was we might be able to come up with a COVID immune globulin. And then the other thing is we might have a manufactured monoclonal antibody. And in fact, we do. We have 2 manufactured antibody products, one made by Regeneron and one made by Lilly. So what do we know about it now? What we know is that convalescent plasma, despite putting billions of dollars into collecting and trying, it really doesn't seem to work. Multiple studies now have suggested that convalescent plasma really doesn't work. We've never made a hyperimmune globulin, and we have made some of these monoclonal antibodies. They're really hard to make. They're very expensive to make, but they do seem to work. So in good studies, they show that they do decrease the severe disease by maybe 2/3. And the thought was that these would be absolutely great drugs for people in nursing homes because they need to be given soon after the diagnosis. They need to be given intravenously. They need to be given in a place where you've got medical stuff around because you can have allergic reactions. And so the thought is that this would be perfect in nursing homes because people in nursing homes would be diagnosed early. People in nursing homes who are already in a nursing facility, they're not going to be exposing new people, and that this would work great. It turns out that although these drugs are out there, they do seem to work and they're available. The rollout of these has been absolutely, totally botched. So you may remember in the fall when the president and Rudy Giuliani and Chris Christie got the disease, they each got these immunoglobulins after they were admitted to the hospital, which is not the way they're supposed to be given. And they were seen as miracle drugs and open to anybody who wanted to use them. Unfortunately, opening up to anybody who wanted to use it then made it totally unclear about who was supposed to be using it. And what happened is it didn't get used in the nursing homes and didn't get used elsewhere. So now in this country, millions of doses of these monoclonal antibodies sit on the shelf unused. And as a country, it's truly a shame that we have drugs that we think probably could work, and yet they don't get used. So this is clearly something we have to learn from this pandemic, is that the next time this happens, we've got to do something better than that. So how else could it end? Well, it could end with a good preventive treatment. We certainly know that there are good preventive treatments for HIV. So there's this stuff called PrEP, that people who use this PrEP medicine just seem not to get HIV. And then there are other preventive treatments for a disease called respiratory syncytial virus. And so this has been one of the areas where there's been a tremendous amount of internet chatter. And so we have spent a lot of time and a lot of effort on these, and there are a couple of things along the way that have been suggested. The first was hydroxychloroquine. And hydroxychloroquine is interesting. Hydroxychloroquine is an anti-malarial treatment. Actually, the Chinese tried it early on. It did not seem to work for them. But then it got somehow this panache that hydroxychloroquine was somehow a miracle drug, and it was going to work, and it was great. And there was a lot of political pressure on hydroxychloroquine. There were a lot of people that were like team hydroxychloroquine or team not hydroxychloroquine, and it became such a polarized battle. I mean, those of us who see patients and treat patients say, oh, I don't know if it works or not. I mean, it could work or could not work. There was certainly some interesting stories about it working. And so we spent a lot of time, a lot of effort, and a lot of money trying to prove whether it worked or not. I think the best data now looking at it is it doesn't work, either as a preventive, as an early treatment, or as a treatment for people who are sick. Although there are people who would disagree with me, I think the data is pretty good that hydroxychloroquine does not work in any of those ways. The current candidate is one called ivermectin. So ivermectin is an antiparasitic drug, and again, we have team ivermectin and team not ivermectin. And there's incredible battles about whether ivermectin works or not. For people who believe it works, it's an absolute miracle drug. For the people who believe it doesn't work, it's like there's nothing there. And so I do not know the answer. I looked today, there's like a bunch of studies, but they're all tiny studies. None are particularly well conducted. They range all over the place. They're just so confusing. And so even though I look at this data all the time, I still can't tell you whether ivermectin works or not. It may work a little bit, may not work at all. It is clearly not a miracle drug. There's nothing to suggest ivermectin is a miracle drug. Miracles don't happen very often. And when miracles happen, they're pretty obvious. So when penicillin was developed for pneumonia, it was not like, no, it was a miracle. People knew about it right away. Other kinds of things that come up as miracles are really obvious, and there's not a lot of argument about it, but ivermectin is one of them. The other one is one called Luvox, and I think Luvox is probably the most interesting. Luvox is an this drug we use for obsessive compulsive disorder, and early on it was seen in France that when disease swept through mental hospitals, that people on Luvox and drugs like Luvox didn't seem to get sick, while others did, and so they looked at this thing called a sigma-1 receptor. And so they did one little study back in August of last year where they found people who were just diagnosed with COVID. They gave each of them a bag. Some of the bags had Luvox in it, some had placebo. They said, take the medicine that's in your bag, and then 2 weeks later call back and see how they did. And the ones who had Luvox in their bag tended to do a whole lot better than the people who had placebo in their bag. So Luvox may work. And then there's like little studies. There's this guy at a racetrack who gave Luvox to some people. The people who took Luvox, none got hospitalized. The people who didn't take Luvox got hospitalized. So these intriguing little studies, but the point is we should know about this. To do a study like this, you'd only need to have a well-conducted study with 500 in the treatment arm, 500 in the placebo arm, and you'd know. Well, we're still, even though we have a low number of cases in the U.S. now, it's not 40,000 cases a day. So in 1 hour, you could recruit enough people to do this study, and within 3 weeks, you could know whether it worked or not. This is not a big long-term study. Like if I eat more carrots, will I prevent heart disease 30 years from now? This is something that is very obvious to do, and you can know in 3 weeks. And in this pandemic, we still don't know. And it really is shameful that those of us who are in the field here trying to treat people, and again, I treat mostly kids, so we've not had a lot of this, but imagine you're an urgent care doctor, an emergency room doctor, a critical care doctor, not knowing about whether these things work or not is just crazy that we haven't had a good randomized control study on these. Now, I think there have been some good randomized control studies of hydroxychloroquine, and I think it does not work, but I think the ivermectin and the Luvox are still totally up in the air. So the other possibility is you could say, well, like diseases were in the past, what you would do is you would wait until enough people had the disease so that it wouldn't spread anymore in a society. And this is how, until the 1700s, every disease was brought under control. So let's take a disease like measles, really a terrible disease, a viral disease. And what would happen when measles got introduced to an area for the first time? It would kill lots of people. The few people who would be left would now be immune. When measles came back the next time, measles would not spread, except for young kids who were not around during the first measles outbreak. But that is a really, really hard way to deal with the disease. So if we look what happened in the New World, when people from Europe came over to America, they wiped out many of the Native American populations with diseases they brought over by doing herd immunity. And so herd immunity does work. If enough people, for example, before we had measles, there were people who died every year of measles, but measles never spread in big epidemic proportions because everybody who was 6 or 7 had already had the measles. And it was rare to see an older person or adult get it because measles gave you great immunity. And so you saw a lot of cases in kids, and there were deaths and disease in kids, so it was really a miserable illness. But in the old days, this is the way you needed to handle it. And so there have been some suggestions that we should just sort of let this blow through the society, and then herd immunity will develop. And so 3 countries in the world didn't outwardly take that approach, but sort of started down that path. So the 3 countries were Brazil, the UK, and Sweden. And so Brazil continues to really battle with this. And what they're seeing in Brazil, although there are a lot of people who have the new variants have come in, and we'll talk about this, that the new variants have come in, and the new variants are different enough from the original that people got it the first time, now got it again. And now Brazil and Peru, which sort of follow that approach, have some of the highest death rates in the world. So herd immunity is a way to do it. The other group that I've really looked at that sort of worked on herd immunity was Sweden. So you remember your Scandinavian geography. There's Norway, Sweden, and Finland. Sweden in the middle has about 10 million. Norway and Finland have about half that each, together about the same number as Sweden. And Norway and Finland took a more stringent public health approach with lockdowns or whatever. And Sweden kind of let this disease go through. The thought being that they would have more disease in the first wave, but then they would have fewer disease later on. Well, it really hasn't worked out that way. And what has happened is they've had about 10 times the death rate of Norway and Finland, and they continue to have lots and lots of disease. So this herd immunity could work, but because this varies so much and there are so many variants out there, this could take a long, long time, and you'd go through a lot of deaths along the way. The other new thing with this is the variants. And the variants are really worrisome because these variants, there are now about a dozen variants of concern and variants of interest out there. And these variants, some spread more, some are more contagious, some give worse disease, some seem to affect younger people. And so it really is an incredibly worrisome situation with the variants. Well, how else could it end? Well, it could also end with aggressive public health efforts. So in the world, different countries have taken different approaches. So much of the Asian world took a really strong public health approach. So China, New Zealand, Taiwan, South Korea, Australia, Indonesia, the Philippines have taken a strong public health approach. They've had anything special, but they did a lot of lockdowns, they did a lot of quarantine, they did a lot of this. And all of those have done an amazing job. When we look at the disease rates, and typically the way we think about it is cases per 100,000 per day. So Douglas County has ranged between 6 and 20 cases per 100,000 per day. These places are all less than one, or many of these places are less than one case per 100,000 per day. And if you had less than one case per 100,000 per day, so we had 5 cases a week, for example, in Douglas County, you wouldn't need to do all these other things, because when you got a case, you could really work on that one case and get it down. And with a few cases a week, we wouldn't have very many deaths. Unfortunately, we in the U.S. are kind of stuck in that area. So what you've seen in those other areas really have done an incredibly good job about taking care of it. So I'll end now with, how is this going to end? So what's going to be the next chapter? And it's so hard to predict, especially about the future. So people have asked lots of very specific questions like, when will we be done with this? Or when will be the last case in Douglas County? And stuff like that is so hard to predict about something we don't know all that much about it and is relatively new. And so in my day job is as a pediatrician, and people want to come in and know how tall their kids are going to be. And there's different ways to predict. But one of the ways to predict is that boys are about half their adult height when they're 2 years and 2 months old. And so it's hard to believe, because you think that you're half your adult height at 6 or 8, but really it's at about 26 months for boys. And so a boy comes in and he's 35 inches at 26 months. And I said, well, from this we would predict he's to be about 70 inches, twice that, when he's an adult. And it comes out pretty accurate. But sort of as a joke, I say to parents, they say, well, I've been doing this for 40 years now, and I've never been wrong, as long as you give me a foot on either side. So if I have to predict he's going to be 5'10", I guarantee he's going to be at least 4'10" and less than 6'10", and I've never been wrong. Turns out I'm usually closer, but if you give me enough bookends, I can do it. So how will this pandemic end? And I see the 2 bookends, and then I'll tell you what I think is going to happen in the beginning. So the bookend could be that vaccination efforts continue, first in the U.S., and then over in the entire world over the next 2 years. So we as a country get a lot of people vaccinated, and we as a world figure out how to get vaccines to places like India, Africa, and South America, and we really bring the disease down. In this scenario, the vaccine hesitant become believers. We've already seen that in the UK and Israel, where people who were a bit hesitant early on have seen the tremendous effect that vaccines have had. So if you remember, the UK and Israel had some of the highest rates of disease just 3 months ago, and now they're down almost to that 1 per 100,000 per day. And in those areas, people were initially a little hesitant about vaccines, have become believers. In this really good scenario, these variants which are out there are biologically fascinating, and nerds like me will follow the different gene mutations and whatever, but they're clinically insignificant. So they're there, they're different, but they're not that different. And the vaccines work, and previous immunity works, and nerds like me will follow it, but it really doesn't make a big difference. And that in this scenario, public health will continue, so people continue to follow guidelines about masking and distancing, work with public health and whatever. And with that, what I would see is a gradual decline in cases beginning between now and the summertime. that by Labor Day you could get rid of restrictions and that the pandemic would be ended worldwide. Doesn't mean that'd be the last case ever, but the pandemic would end worldwide by late 2022. So that's the optimistic thing. And to do that, great vaccination efforts spread around the world. Vaccine hesitant become believers. Variants are interesting but not significant. Public health continues, and that's the best case scenario. So that's the one bookend. The other bookend is that vaccination efforts continue, but they kind of falter at the 30 to 40% range. That is, early on there was a lot of uptake of the vaccine, but they sort of falter at the 30 to 40% range. In this worst case scenario, we start to see new vaccine side effects discovered, which further reinforce vaccine hesitancy. And I think we've seen a little bit of that with the J&J and the AstraZeneca. That in this bad scenario, vaccination becomes increasingly political, so that team vaccine versus team not vaccine spreads the U.S. In this worst case scenario, the variants become more contagious. They become resistant to previous infection or to vaccination. So vaccine doesn't work, previous infection doesn't work, and they're more contagious. And that's really a nasty part here. We've seen a little bit of that. We think in Brazil that many of the previously infected are getting infected again. That we see certainly in India that people who were vaccinated, so very few people in India were vaccinated, but some doctors were, and many of them have gotten ill, suggesting that the vaccine doesn't work very well against that variant. My worst case scenario is Africa. So Africa has had very little disease during this entire pandemic. So when you look at the waves, the first wave, second wave, third wave, fourth wave, they've had 0 waves, and they've had very little disease in Africa. And we don't know if they've had disease and just haven't seen it, but we think they just haven't had the disease for whatever reason. It hasn't arrived yet in Africa. But if it did arrive in Africa, Africa has some of the most densely populated cities in the world. If you think of Kinshasa or Nairobi, these are really, really dense cities where people have had no experience with the virus, and it could spread really widely there. And because they would already start with one of the variant viruses, they're not going to start with the original virus. It's almost not out there. They'll start with the UK variant, or they'll start with the Brazilian variant, or they'll start with the African variant, or the Indian variant, and it'll go from there. In this worst case scenario, people give up on public health. They say, look, I'm so freaking tired of this whole pandemic. I just don't want to do anything. And people continue to gather and spread the disease. And with that, what we'll see is that cases will go down, but then a new variant will come and they'll go up. And then you'll have a bad variant that'll be vaccine resistant, and it could really go up, and we'll be on this roller coaster for the next however long. And then if the world can't get together and vaccinate the people in Africa, or the vaccine doesn't work as well, what you'll see is this roller coaster of disease along the way. Well, I don't think it's going to be either of the bookends. I mean, I don't really see either of the bookends happening, so it's likely to be something in between, which is going to be, unfortunately for Douglas County, about where we are now, 6 to 20 cases a day, some hospitalizations, deaths. You go weeks with less cases and then weeks with more cases, sometimes not understanding it. And it's going to be sort of a trudge along the way. So I don't know which it's going to be, but I think just like the kids who I say are always going to be more than 410 and less than 610, it's going to be somewhere in between. But usually the middle thing, I'm pretty close. And I think in this case, in the middle thing, I'll be close. We're not going to be done with it, but it's certainly going to be better than it was in the past. We're not going to have no deaths, but I don't think we're going to have the terrible death things that we saw in New York or in Italy back before, and I think it's going to be somewhere in the middle. All right, so that's my presentation. So let me tell you, in the world, the disease is all over the place. Terrible in India, terrible in South America, but relatively quiet in the U.S. But then busier in Oregon, but less busy in Douglas County. So I wish it's all over the place. So let me see which questions we have here. All right, so David says, the FDA is getting ready to approve the Pfizer vaccine for children 12 years and up. Is there any data regarding risk for fertility? Now, there is absolutely nothing to suggest that this would have any effect on fertility. This is an mRNA virus. It does not get into the nucleus of the cells. It does not get into the nucleus of the eggs, so it should have no effect on fertility. However, this is a popular internet meme that I don't want to give it because it's going to make my daughter infertile. There is absolutely nothing to that. So Martin says, can you tell us what autopsies of people who died with COVID are showing? So interestingly, when we watch TV, everybody has got this fancy autopsy done by a forensic pathologist. It turns out that in the US, the number of people who actually get autopsies is very, very small, and usually only related to cases where there's criminal activity. So in an entire year, there's only less than a dozen autopsies done in the US. However, in academic centers, there are more autopsies done. And what those show is that people who have COVID have really ugly looking lungs, dense, fibrotic lungs that really look terrible. And so that's what they're showing. It turns out that there's not a lot of disease in other organs. So when you look, there's not a lot of specific damage to the heart or specific damage to the liver. So this disease appears to be mostly in the lungs and in the blood vessels in the body. So would you be able to tell the ages of people who were hospitalized? And I just pulled that up. So we don't want to go ahead and give away anybody particularly, but we have several cases in the 30s. We have several cases in the 40s. The 50s actually appear to be the most common. 1, 2, 3, 4, 5, 6, 7 people in their 50s. We then have 3 people in their 60s. So I'm 65. All these people are younger than me. So to have all of those people hospitalized over the last 2 weeks, younger than me, is just frightening. We have somebody in their 70s, and then we have somebody in their 90s. So this is so different from what we'd had before. So early before, we have a lot of people in their 80s, occasional person in their 90s, a bunch of people in their 70s, some people in their 60s, not everybody in their 50s, 40s, and 30s. Now what we're seeing is a lot more younger people hospitalized, and this is what many people are seeing, we think, again, because of the variants. So it's not that the variants specifically attack younger people. What we think is the variants don't attack seniors so disproportionately as younger people. So do we think we'll have a big outbreak of people flying back from India? Absolutely. So if we don't learn from the mistake we made with China, if we do not learn from the mistake we made with Europe, shame on us. So the story is people will fly back from India. Perfectly logical. But what they need to do is they need to quarantine for 2 weeks. And so other countries that have done a good job of this said, look, there's no getting around. You come back and you get quarantined for 2 weeks. So in Taiwan, was done really a great job with this. When somebody came from another country, they had a special person pick them up at the airport. Didn't get your luggage, didn't do anything. They picked you up, they moved you right to a special cab that brought you to your house, and they said you must stay in your room for 2 weeks. And with that, they were able to decrease the cases. So I really, truly hope that we learn that when people come back from India, they can't be stopping off and visiting relatives and going back to work right away. They need to quarantine right away. So Vicky says, just heard the news saying we're going back to high risk. Why when our numbers have been so low? Well, our numbers were low until this last week. And if you look in this last week, we had 4 days in last week with high numbers. We were just, to be in the moderate range, you need to be 50 to 100. to be in the high range 100 to 200, extreme range 200 and above. We were at 103 per 100,000, so just missed it. So Debbie says, I got my second Pfizer on April 1st. Is it okay to get my shingles vaccine now? Yes. Now, when they did the studies, they did not want people to have any other vaccines within 2 weeks of their COVID vaccine. You imagine if you got a shingles vaccine on Saturday and your COVID vaccine on Sunday and then had a reaction on Monday, it would be hard to know which it was from. So they asked people to be at least 2 weeks apart, and that's our recommendation. But you're at least 2 weeks apart, go for it. So are you seeing cases of flu and allergies together in patients, or COVID and allergies together? I think I had both the flu and allergies, which have been terrible. So there's been very, very, very little flu going around this year. I looked at the Oregon numbers. They're just a handful of cases in the entire year. So there is not much flu going around. Are there allergies? Of course, just look outside. There's so much stuff blooming. There are clearly allergies. So allergies have been around. Now, I will tell you, our number one source of missed COVID diagnoses is, I just thought it was allergies. I saw one today where there was one in another county where these people thought they were just allergies until everybody at the plant now had just allergies. And when they hadn't had allergies before and they tested when they actually had COVID. So early on, the symptoms can look like allergies, or they can look like allergies. So what's the recommendation? Well, if you've not had allergies before, it's pretty unlikely that you would develop them at age 30, 40, or 50. Allergies almost always get better with antihistamines. So that if you have allergies and they don't get better with antihistamines, you should think, well, maybe this is not allergies. Allergies almost never, they can make you feel miserable, but they don't really make you feel sick, right? So you can have stuffy nose and runny nose and whatever, but you almost never feel tired, fatigue, chest pain. And so if you're having symptoms, you almost never have fever with allergies. So if you're having any of those symptoms, it may well be COVID. So my recommendation is, unless you're having the absolutely typical allergy symptoms you always have, consider that it could be COVID. Stay home, take an antihistamine, and if you're all better in a day, it's probably not COVID. If you're not all better in a day, please get tested, because I will tell you the misdiagnosis of allergies has been our number one misdiagnosis. Our epidemiologists who review all these cases just pull their hair out when we hear about another person who worked for 3 or 4 days thinking they just had allergies. And then when you go back and they've never had allergies before, they didn't get better with antihistamines. So it's like, oh. So allergies are terrible. Now, this time of the year, the allergies are usually going to be to trees. And again, allergies to trees do certainly occur. But again, allergies almost always get better with allergy medicine and almost never make you feel, other than the place where you have allergies, feel sick. They almost never have you have fever. So again, if you are if your allergy symptoms are the least bit atypical, stay home. If your allergy symptoms continue, get a test, because these people going to work when they thought they had allergies are one of our major causes of preventable spread. Okay, well, it's 7 o'clock. I promise my staff here I won't go past 7, so that people can go home and be with their families. So thank you for watching. If you have other questions, you can send them to us at Facebook questions at DouglasPublicHealthNetwork.org, and we'll get to them first thing on Friday. Again, Dr. Bob Dannenhoffer, the Public Health Officer, Douglas County. Be safe.